we were on mute.
Everybody's on mute.
They were on mute during our introduction, so they may not know. That's what we're asking them to do.
Are we on mute?
We were,
We were.
Oh, we were.
but now we're not.
Okay. Can you hear us now, Patty? Can't hear you.
Yes, I was like putting the sound up all the way and I'm going like, I was just on a Teams meeting and why is this one not working? So anyway, yes, I'm here, Patty Adair, Deschutes County Commissioner.
Okay,
Thank you. Thank you. Thank you.
Cameron. Can you hear us?
Hey there, Cameron Fisher here, board member.
Okay, thank you. And Callie.
Hi, everybody. My name is Callie Rumley, and I'm with Pacific Source, the behavior strategist for Central Oregon.
Hey, nice to have you here. Okay, your agenda building, what kind of things anybody have? Meetings? Twitter? Anybody? How's your program going, Mike?
Well, we could put on the agenda maybe an update. It's not a big update, but it'd be good to have an update of the public safety campus, what we are, where we're at, and what areas that my teammates, the sheriff and the other captains are talking about as the first phase that we want to get started. So we could put that as an agenda item.
Okay.
If you want to talk about today, we can do that.
No, we'll put you on the agenda so you can have whole time. Just wondering if you got people hired for your MAT program or.
Well, we can talk about that too. Let's put that on there. MAT is up and running, just started last week.
All right, that's what I need to know.
Congratulations.
Thanks.
So we'll ask Holly to give director's report.
Yes, I got my handy dandy sheet.
You like it?
Great. I love it. This is, I was actually looking at, unfortunately, I did not have a lot of time to prepare, but this helps me because I don't need to.
We don't need to write it down, just shoot.
Yeah, it's awesome.
Thank you.
So I don't have to, I'm not gonna talk about all these points, but there's a couple of things I do want to touch base on. Just a couple of highlights. The Stabilization Center did have its 3-year anniversary. There's been a lot of media attention around it. So in case you saw that, that's very exciting. We also have a groundbreaking, or not we, Lapine Community Health Center has a groundbreaking ceremony for the new building that they are building, which we are hoping to be a part of. We got to kind of go through the steps of the approval process and all that, but we have a great partnership with them out in Lapine, and it's an amazing opportunity for us to do some great integrated work out there. So if anybody's available on August 10th from 5 to whenever, come out there and celebrate with that community. Just another thing on kind of some space stuff are, as many of you know, I think I told you this in a previous meeting, the kind of administrative folks in this building, myself, Janice, Heather Keisner, Public Health Director, a couple, Cheryl Smallman, our Finance Director, our Operations Officer, we'll all be moving out of this building and into a leased building that's just steps away, the Wyatt Building, which St. Charles previously occupied and is now leaving. And so we're taking over that building. IDD will also be moving into that space. Environmental health is moving into that space. So we're just growing a lot. So we've had to lease some space. It's going to make this building really a more direct service providing building as opposed to kind of how it's historically been with administrative staff here. So bringing up some offices to do more direct client work. So that'll be happening here in the next couple of months. There's a big move for IDD that will be happening. They will be moved. So as you all know, we moved into a new building in Redmond, the Kingwood location. We are adding a drop out there that Shannon's team will run and operate. So that part's not quite done yet. So there hasn't been a grand opening for that yet. But it's coming. So once that happens, so Paul's team will be moving into the previous Redmond building known as the Antler building. So we're going to be doing a remodel there as well, which will also free up room in Shannon's Bend location at WSSB, which remodel happening there as well. So we have a number of rather large projects happening because we have just outgrown all of our spaces. And so now is an opportune time to really redesign them in the way that makes the most sense. So that's all happening. Other big items, as some of you know, I've been, all the counties are involved in county financial assistance agreements. Our IGA with the state, with Oregon Health Authority, we're in negotiations around those. There've been two really big sticking points, that we've been kind of going back and forth with the state on. One of them is we would like language in our contract that says we can provide all these services that are listed in there, which there are many, with the term subject to availability of funds in there. Because we know, we've proven, we've discussed many times, we are not actually funded to do all the things that are in our contract. We hope to get there, but we aren't there yet. And so we're really asking for that latitude in our contract that says, you know, if you have enough funds to provide all these services, you will provide these services, like most other contracts would say. So that's one sticking point. The other sticking point, as you all know, we are, there's been a lot of work done with the aid and assist population at the state hospital. So folks who are unable to aid in their own defense because of their mental illness, they end up at the state hospital, often getting stuck there. And then so now there's been a new judge's order that now requires these folks to be released within certain timeframes, whether they are ready or not. So we have people coming out of the state hospital. Kara's team oversees this work, that are really, really not well, very much not well. And are coming to the community often with no real plan other than county, here, take them and restore their ability to participate in the legal process, and good luck with that. And so what we're asking for, because that, as you can imagine, we're taking on enormous liability by taking someone who really should be in a state hospital level of care, in our opinion, into our community. So we're asking for indemnification language in our contract that absolves counties of the massive liability that they're taking on to do this work that has been put upon them. So our board of commissioners has been very involved in this conversation, and so that's the sticking points that we're trying to negotiate with OHA on right now. We're in the middle of that, so more to come.
So that's their care plan, is to just give them to the county, and so are they actually being released kind of to the street?
Yes.
Yes. That's their discharge plan.
Often. Yeah, and it's happening. I mean, that happens quite frankly with civil commitment oftentimes too. So we have these certain populations. I mean, these are our people that we want to serve. They're very, very ill. They are often houseless. They are difficult to engage in treatment. They don't want to participate in treatment, but they are needing supports. And so that's our job as a CMHP. But these systems, unfortunately, we don't have adequate resources to be able to serve the population in the way we need to. We don't have enough secure residential facilities. We don't have enough regular residential facilities. We don't have access to the state hospital. I mean, like the list goes on. And so what's happened over the course of time is the state continues to make decisions to send these people just back to the community, which great. Okay. We want them in our community, that we want to serve them, but they haven't given us the resources to do it. There's no safety net. And then we just kind of hold it. And it's really difficult for staff who have to do this work every day to know that we want to help this individual, but there's really no place for them. And so that's the piece that we're working through with the state. There's been, thankfully, we're fortunate that there has been a lot of legislative financial investment in behavioral health the last 2 years. We got another tranche of funding that we're still waiting to see what that all looks like. But, you know, we're so far behind. We're so far behind in where we need to be that any investment is really kind of almost just getting us to where we should have been, not giving us more. And placements, as you all know, take years to build and develop and operate. And then we add to the staffing crisis to all of this work. It sometimes feels untenable. So this is why it's such a sticking point for us this year, is that yes, this has kind of always been a reality to some level, but now it's just compounded and it's untenable, and we really need some protections in place. So that is what we're working on with the state. I'm driving to Portland every other week to do it.
So you said something at the very beginning of that. It was like a sentence, and then it said, as a result, a lot of people are being basically discharged. What was that sentence you said?
Because of a judge's order. You'll hear us talk about the Mossman order. There was Judge Mossman who did an order that basically, and this is all stemming because there's statutory language that requires people who are under aid and assist, who are in this aid and assist process, to get to the state hospital within a certain amount of time. And they were not able to do that. And so they were in violation of statute, and OHA was being held legally accountable for that. So a bunch of people were trying to try to solve the problem. Well, instead of solving the systemic problem that's really at play, which is maybe we shouldn't be criminalizing people with mental illness for low-level charges. You know, that that's too big of an issue to tackle right now. So they do these quick kind of Band-Aid fixes that protect OHA.
So basically, they could not meet their agreement by getting people securely housed. So they are unsecurely housing them into the community.
Correct. So they can free up beds so that they can get people in within 7 days requirement.
Well, I think it's important that the DRO, Disability Rights of Oregon, they had agreed with the Mossman order because they don't want people lingering.
In jail.
Oh, they're in jail. Gotcha.
Yeah.
So, and they believe that individuals still have rights regardless of where they might be in their mental health
Yes.
issues. So it is very complicated for judges, courts, and all of us. Because to guys like me, very easy to solve it, but our counterparts that, you know, have a different idea on.
Right, and I mean, and it does solve one problem, but it creates another problem. So, and I think unfortunately what we see is folks coming out, they're more likely to come into contact with law enforcement, get rearrested for another charge, end up right back into the jail where we were trying to get them out of. So it's just this like kind of.
So jail, gotcha. I forgot the jail part.
Yeah, no, and it does solve.
All of them, that's one section of the Oregon State Hospital. But it's now the biggest one because there's no other beds. So in order to get there, you have to go through jail to get there.
And so unfortunately, because of this systemic issue, the state hospital really has become primarily a place for people under the criminal justice system, the aid and assist process to go. And now we cannot get people under civil commitment, which is really a nice way to prevent people from having to enter the criminal justice system to get help. So our civil commitment process is not working because of this issue. So anyway, I could go on and on about this, and I won't, but that's what we're working on. It's a pretty big deal. It's all the counties are engaged in this process. A handful of us are in person negotiating this, and it's not going as quickly as I would hope, but hope is not lost yet. So we will keep you posted.
And I don't know if it's still happening, but part of the absurdity of this whole process to me was when I read that the Moxman order was set out because we're in violation of the federal DOJ, and the Department of Justice said that we weren't meeting the requirements. And so OHA in that process, and then the Moxman order came about because of a contempt of court.
To hold OHA director in contempt of court.
Yeah, so they just started budgeting to pay the fine.
Yeah.
Because they were getting fined for being out of compliance, so they just paid the fine instead of fixing the problem.
Right. Yeah, now this was their, so it's really, this is really difficult work for our intensive teams who do this aid and assist work. It's definitely increased dramatically. And so it's a big deal for us at the county and in our negotiations. And so we'll keep working on it, but I'll keep you posted. Let's see, audit findings or an audit reports. We had Pacific Source audit and we did quite well this year. So really excited about that. We're still waiting on kind of the final report. I mean, my staff I haven't even announced this to them yet, but normally each year when we get an audit, there's all certain findings that you're going to get because we have an enormous amount of requirements. Like you have to have signatures within a certain amount of time. You have to have your billing code justified. You have to have, all the things. So it's not unusual to get findings. And in the past, we've probably gotten anywhere between 10 and 15, things that we then correct and we fix and we do some training. This year we only had 2.
Wow.
So it was awesome. We were like, no,
That's wonderful.
we only had 2. So yeah, and they were the typical ones, nothing big, very small, minor detailed stuff that easily fixable and trained on. So we were really proud about that.
That really speaks to your staff and
Yeah.
this program coordinators.
It really does. And if you all saw the list of things that are required of staff as they document the work that they do, you would fall out of your chairs. You would. It's unbelievable what they have to consider for every single note that they do. And the fact that we only had 2 findings is kind of astonishing.
Almost none of the things on the list are things that the people that we're serving has come to us to complain about.
Never. Not one.
This is what I always kind of chuckle.
It's true. Yeah, you would not notice anything about client care from those findings whatsoever, but it is what we have to do. This is part of being in a government system and, you know, all of that. So we were really proud of staff for that.
A lot of the clients have figured that out too. They just-
Oh, yeah.
So-
Oh, yeah, they know. I mean, it's,
Clients know.
yeah. And I think if we were truly listening to consumer voice around some of this, our intake packet would be significantly smaller than it is.
Oh, so true.
But yet our intake packet keeps growing every year. So it's just, I really do wish the state legislator, everybody, when they talk about listening to consumer voice, they would listen on some of those more mundane things because they actually do really impact their experience here at behavioral health right from the first interaction they have with us.
Well, even the job that I do, by the time they get to me, they've done the same form 4 times. That's because, we have the EHR, so you figure you could just upload the form and within a month, maybe not too much has changed. 4 times before they can get service. That is intake fatigue.
It is. You should see our intake packet. How many pages is it? Like 10, 5, 10, something like that. And I mean, we've tried to whittle it down and
They say that's the reduced version.
yeah, that's the reduced version because we've only whittled it down to just the OAR requirements.
Yeah.
But it's still. So. Let's see, I think. That is probably still waiting here on our grants. We'll probably hear in August sometime around our 2 grants that we wrote, the homeless outreach one and our CCDHC expansion one. So keep posted on that. Hopefully by next time we'll know something, if not the following meeting. Yeah, I think that's all I have. Anything that you have a burning question about that maybe I didn't touch on?
I guess Mary, what I read from NAMI, that basically out of the legislature, what we've got now is probably what we'll have for the next 2 years. Really not much of a boost other than the 988.
There was, well, I'm still waiting to see. I mean, it kind of depends on how the funding formulas play out, how OHA decides to, you know, dole out the money. But there was a pretty significant investment in residential. So I do, which is great. We need SUD, and I think SUD residential in particular, but again, these are gonna take a while before we see it all come to fruition. But it's, so there was that's exciting because we need all kinds of residential, SUD, mental health, all of it. And then I think there was a little bit of investment in workforce, so we'll see how that plays out. But the pay, so one of the things that's challenging for us is our pay equity was going through the legislature, which is really what requires, you know, that it's a good thing that makes sure we pay people equitably. But one thing, and kind of an unintended consequence of it is by offering bonuses, you can't offer hiring bonuses without it being kind of part of the pay equity process. So giving everybody the same amount of money. And so trying to incentivize certain recruitments is very difficult because we're not allowed to offer hiring bonuses when many nonprofits and other places are able to do that. So,
And you can't provide a bonus mid-year or end of year either,
right.
which nonprofits can do.
They can also do. So it's difficult to compete in that environment. We were hoping they were going to make an exception to that in the legislature because of all the shenanigans and everything that was happening. It didn't make it through. Not that anybody was opposed to it. I think it just one of those that died.
Yeah.
So we'll keep watching that because we really, really need that, particularly for positions like our intensive services and crisis in South County and places like that that are struggling more than others.
I guess if you offered everybody a housing incentive or stipend, that would not go over well, would it? But that would be a way to.
I tried
a little bit.
Yeah,
really?
there's some issues with that. Like I couldn't get it through the process because
Yeah,
it's
it wouldn't have a
complicated than
barrier.
it sounds.
Well, that is
Because I wanted to do it for South County. But we were able to secure a differential for our South County employees that is incentivizing them separately. So that's made a huge difference and we're almost close to being fully staffed. If everybody shows up, it shows up on the first day of work, we will be fully staffed. So we're it does, these things work. So.
Yeah.
Yeah.
I just wanted to make a comment about Amber Clegg. If she was here, I totally would give her kudos. But with South County and the Lapine work, she's been advocating for Lapine like since 2019, maybe even before.
Oh, before that, even 2015, I think.
I mean, this is like so to see it come to fruition and see this collaboration start to really materialize is super exciting.
And Kristen has really done a phenomenal job building relationships up there, and Kristen has been navigating this storm of being incredibly short-staffed out there and finding creative ways to keep that clinic open during a really, really difficult time.
With high population needs.
It's a very high need population, yeah,
Tough one.
it is, but all the hard work paid off.
Looks like it anyway.
And with the Pine Community Health Center, new project, and all, there's some really exciting stuff about to happen in South County, long overdue, and we're excited about it.
Thank you very much.
Yeah, thanks.
Good. So let's run a little behind, but don't worry about that, Christie.
Okay.
Go ahead and take off and we'll squeeze things at the end if we need to.
Okay, so again, I'm Christy Durr with St. Charles. I've been with St. Charles for 13 years on the human resources team. My area of responsibility, I work with caregivers through the leaves of absence, disability claims, workers' compensation, accommodations, anything really related to absence, and a lot of benefit oversight too with plan design and eligibility. Rebecca Berry is our VP of HR, and she's was asked to come and she wasn't able to, so I'm here for her. And there are some items that she asked me to kind of touch on, and I don't know exactly what stemmed the invite to come here. So feel free, ask questions, push back, whatever makes the most sense as we go through this. And Christina, did you have anything to add?
Yeah, I could jump in and kind of say what, where the invite came from. I think a group of us, a small group of us were kind of talking, but really it was my idea as well to just to build bridges between the health system and other community settings, especially mental health focus. And looking at the whole health system as this population, our largest employer, 4,000 plus employees who have been holding a lot of trauma probably from the last few years of the pandemic. So just letting us know how we can assist the population. Kind of what I would think of.
Perfect. So this will be a good kind of jumping off point for that. So it's just some little facts and things that we have done as a health system and an employer in the area. And then towards the end, kind of what we're seeing and feeling from our caregivers. Okay, so we continue to offer well-being programming for all of our staff, and we did have some new offerings implemented this year. We have the critical incident stress management team that continues to offer debriefings for staff who have experienced any kind of a difficult situation or interaction at work. That can be utilized in many different ways, if that's patient related or maybe it's coworker related. If there's a loss of a team member, then that CISM team can come in and help with that too. For post-pandemic recovery, we increased our caregiver assistance program. So that's our own internal EAP or employee assistance program. Previously was 3 visits per year, and we've increased that to 12. That was effective July 1st of this year. So anybody that had already met their maximum or were on an extended unlimited amount through the pandemic, now as of July 1st still has another 12 for this year. And then starting in January, it'll be 12 per year. So that's a huge increase and very well received from the caregiver population. We partnered with the Headspace app, making it available to all caregivers and 4 of their family members, so at no charge. And this is something that just gives the access that normally is, some people probably wouldn't pay for it. They wouldn't want all of that. And so it gives them tools, I guess, to put in their tool belt. They can have it on their phone. They can use it for mindfulness, stress reduction, mental health, their well-being resources. There's a lot. It's a very big variety of tools that are available on that. That was something that the team worked hard on getting that partnership with Headspace to go live with. We've expanding our coaching options with all staff having availability to the wellness program, where previously you had to be enrolled in the benefit plan on the medical plan to be able to participate in the wellness program through Engage for Health. So now that we were able to recognize that just the benefit status of somebody doesn't impact whether they should or shouldn't have access to that benefit. So we've done that. And then some trends that we're seeing happening in the workplace, we do have a heavy focus on mental health and well-being. Our caregivers are very, they're very vocal, I guess, to say we need more resources that help support mental health, that help with our well-being. And to your point, it is a tough time that everybody's coming out of. The last few years have been a little weird. In healthcare, the stress of that job itself, I think, has added on top of, maybe you've got a kid at home that's got isolation issues because they can't go to school, but you have to still come to work to be the frontline caregiver. So there was a lot of that. Inclusivity and equity are very important to our caregivers also. I think there's a big push for that everywhere right now. So I don't think that's unique to St. Charles at all. Compensation and work-life balance are big issues for people that ultimately kind of leave them wondering, do I want to jump and find a job somewhere else? I think we're all experiencing the trouble with hiring right now. So you have the bonuses that are being offered, and when you can't compete with that, it makes it tough. Our caregivers are really valuing hybrid work if they're not in a patient care where they have to be hands-on. That hybrid ability to stay remote part of the time and come back in the office part of the time has been huge. We see it, but you see the flip side of that too. There are definitely caregivers that want back in the office all of the time. Like, for example, my department, human resources, we don't even have office space enough for all of us to be in the office now. So we've went from one building to another, and then out of that building back to the first one, but in a different section, and not enough desks. And so it's that, I think, all kind of contributes to just the stress of that, not being able to really know where you're going to be each day. They're overwhelmed, tired, seeking work-life balance. In an ability to help with that, we also just announced effective July 1st an increase to our ETO accrual rates. So, and that's our earned time off, or PTO. You might be familiar with vacation and sick time all in one bucket. So the rate of accrual is going up by a total of 24 hours a year for a full-time caregiver. So, for example, if you've been there over 10 years, you're accruing 12 hours of ETO every paycheck, which is every 2 weeks right now. So that's a significant jump. We are attempting to stay true to not increasing the maximums you can accrue in your bank, because then it's actually forcing you to take that time, and that's kind of the whole point, is to take the time off that you have available. We also have worked really hard recently to do a better job of publicizing our financial resources that are available through Fidelity. Fidelity handles our retirement plan and all of our spending accounts through the benefit plans for medical. And so they offer a lot of resources. There's webinars, there's one-on-one meetings, and we hear that financial stress is a big contributor right now to overall well-being and mental health of people. So we're trying to get that out there and make it aware for people that they can use that. For compensation, we are still performing an annual market review. We also have the Pay Equity Act to keep in mind. We adjust pay ranges and caregiver pay as necessary to remain market competitive. We don't utilize a pay for performance model. It is all tied to market. So, and admittedly, that gets a lot of feedback. Some people like it and some people hate it. They don't know why. If I'm a top performer, I can't get more pay than the person next to me that barely skates by. So it's always being evaluated, but current state is it is paying to market. And that's where you come up with the across the board wage adjustments every Q1 for all eligible caregivers. It's been 3 years consistently, or 3% the past few years. This year was up at 5%, given the increase in costs of living and stuff like that. We increased the shift differentials for those caregivers that are working nights, weekends, evenings. In 2022 and 23, those have gone up to reward folks that are taking those kind of maybe less desirable shifts.
Are you able to say what those are?
I don't know what they are.
Okay.
Yeah, okay. Sorry. We have offered a variety of bonus programs to strengthen staffing around the health system. And this is where I think there's a little bit of taking the risk on with the Pay Equity Act of still being able to offer some of those bonuses as the compensation team has seen necessary. We do sunset most programs, but continue to offer the sign-on and retention bonuses sparingly. I feel like our caregivers are still feeling the burden of understaffed units. So they're working more, they're working harder when they're working because they just don't have the staff levels that would be ideal. With that, we do have a new RN residency, new grad program. It began in August of 2021, in an effort at that point to hire RNs in a changing workforce. St. Charles was one of the last hospitals in Oregon to implement this. And so we had a very hard time hiring experienced nurses due to the we did not have a hard time hiring the experienced nurses because they wanted to live in Bend. But now that whole schematic has changed and we no longer can lean on the fact that, oh, everybody wants to come to Central Oregon. So we don't really have to do these programs. That doesn't exist as much anymore with the cost of housing and everything else. So this is, and experienced nurses are going into traveler positions. So it's really important to get these new grad residency programs up and going so you can build that maybe loyalty to your organization and everything. Starting the program during COVID was very difficult to remain competitive because most health systems, again, already had their robust programs in place. So being the new guy on the block was a little challenging. They go through a comprehensive training program with our education department and nurse preceptors before they ever hit the floor being released to do their own independent work. They're the RN residency to remain competitive with the others, we had to institute some bonuses. And so here are some of them, at least. There's a $5,000 in-state relocation bonus with a 2-year commitment. $10,000 out-of-state relocation bonus, also with a 2-year commitment. And a sign-on bonus of $10,000 for acute care RN residents and new grads working in acute care departments, which is where our current need is highest. And also having to commit to a 2-year tenure with St. Charles. We've hired RN residents since August of 2021, 106, and we're forecasting 146 in the upcoming cohorts. So it's working, really helping. OHSU is now offering to repay their RN's tuition for an agreement to go through their new grad program and a commitment to work for the organization. So that's something else our compensation team is looking at. How can we implement something like that? So it's kind of fun. It's challenging, right? But it's also kind of fun to see all of the different things, to get creative and try to show that that's the best place to be. We have a CNA 1 trainee program too that began in March of 2020. CNA positions are historically, they're very, very difficult to fill and keep filled. The tuition in COCC's CNA 1 certification program is paid for by St. Charles, and they're being paid an hourly wage to attend. So it's really a great, great program for somebody who wants to head in that direction. Internal caregivers attend classes in administrative and entry-level roles were hired to the program to change their career path. So it gives them that opportunity because they can't maybe afford even just to go to school and not work. So now they are getting paid as though they're working and their tuition is being paid. So it's huge.
There you go.
Yeah. We've hired 14 cohorts, and each cohort has been anywhere between 8 to 25 people in the cohorts. I'm not going to lie and say they're super successful all the time. Sometimes people wash out right away. Sometimes they get through and then they wash out. So it does have that, but you're going to have that in any kind of a hiring situation. But our number of open full-time CNA positions was at over 100 at one point, and now it's under 10. Wow. Yeah, it's huge, huge, huge. 184 CNA trainees hired since March of 2020. And then once they graduate, kind of about this program is they go through COCC, they graduate, and they're placed in various units throughout St. Charles. And we require successful completion of their certification exam as well. And now it's fun to say that our hires are actually outpacing our voluntary terminations. So that's good. And that was really all I had in slides. There were some questions posed earlier about just ideas that we're hearing throughout the health system. And in my role is kind of unique too, because I do hear from a lot of our caregivers that are out on stress claims or mental health claims, either a work comp avenue or non-work. And both can have their pros and cons, and it's tough when somebody's out for their own mental health. And what we often wonder as a team is how can we try to put more tools out there to catch the stress and not have it rise to the level of where they have to seek treatment or it's so difficult to seek treatment. And so that's just something we ponder a lot. It's like, how do we help just to deal with things that are coming your way, with the bad days and things like that. So I don't know the answer to that, but it's something that I think is worth trying to look at, especially when you have a need for facilities that don't have the staff or don't even have the buildings and you can't treat the people that you do. So how do you try to get ahead of that a little bit? Finding that balance before, and the balance too between, we hear a lot about reducing the stigma of mental health right now, but we don't hear a lot of, well, how do you not get to that point? How do you help people understand that not every day is a great day and that's okay? You grow and learn from that. So I think there needs to be tools more based around that as well.
Like resiliency.
Yeah, exactly. And we're hoping that Headspace is a start to that, but not everybody's going to use that. And it's just something to try to think about, group activities, whatever, that doesn't rise to the level of needing to seek treatment. Because I might be stressed out, but I don't really feel like I need to go make an appointment somewhere. But how do I find a camaraderie or whatever to try to just realize that that's kind of almost normal moving forward from there. That was it. Did I catch you up on time?
Yeah, way ahead of us. I'll say one thing that I've been reading a little bit lately about is not calling it stigma anymore, but discrimination.
Yeah.
It really is, it's not stigma that keeps these people from getting services or getting jobs and things like that. It's really just discrimination.
That's a great call out.
We might hear more about that in the future. I don't know.
Totally.
And I'm interested, hearing all the publicity going through with the strikes and stuff. They keep talking about mandatory staffing, that the hospital will guarantee mandatory staffing. Are you guys, you're not there yet, right?
No.
You think you'll ever, I've never, 35 years, I've never had enough staff where I worked to do it. So I'm kind of curious, how was the agreement?
I have no idea. I don't know. I haven't been involved in any of that, like that mandatory staffing conversations or anything. I know we have executives that are involved in that on like a state level. And then our contract, our labor management committees are talking with the unions about it, but I don't.
You're not involved.
I'm not, unfortunately.
It's more labor.
It's come up in behavioral health and on certain teams before and part of union discussions and things. And thankfully we have a pretty good working relationship with our union. And we've been able to kind of understand like mandatory staffing. I think everybody agrees we would all love to have this amount of staff to do the work. Like all of us agree with that.
Right.
And the reality is that we don't have control over that when you deal with things like, a workforce shortage and all of that. So I think the compromise is really around what we'll try to do to seek the supports necessary when those situations happen. We can't guarantee them, but we can promise that we will, seek, we'll offer stipends and things to pick up shifts. We'll do some creative problem solving around that. And we did that certainly within the crisis arena where this kind of conversation comes up a lot of like, I need this many people to do this work. And that, well, I would love that. And what I can do is promise that when you get to this level, I'll reach out, I'll get some on-call support wherever we can. We'll pay them stipends. We'll do all these extra things.
My mind is trying to wrap around the concept of mandatory staffing. It implies that there's some kind of an ill intent to not staff to a certain, none of us have any intent to not, like you said, Captain, it's been in your career, you've never had enough to do what you want, and it's not anything that's under your control.
That makes more sense, actually, the intent instead of managers not providing staffing in that we do things to keep the workflow going.
Yeah.
So people don't get overworked.
When you say mandatory, what does that mean? I mean, if you need 30 people, you only got 28, just close down today.
Right, and when that's not an option, when the services have to continue, that's not an option, like, and so, for certain, there may be an option in some settings, but not in the sort of mandatory type of like critical service areas. So it's worked well for, it's been a way to find some common ground.
So I have a question about, how heavily reliant is St. Charles on traveling nurses?
It's getting much better. For a while, it was, I don't have a percentage or anything like that for you, but for a while it was very, very heavily weighted on travelers. The COVID vaccination requirement has helped us with our staffing too, now that it's not required.
Okay.
We're seeing a lot of rehires come back that had left, so that is nice. And that's helping to even out that traveler versus full-time regular employee. It's instead of being travelers here and regular here consistently.
Because travelers are more expensive.
Travelers are more expensive.
Which then would impact your staffing ability, right?
Right, right.
Okay, and then do you have the flu mandatory?
No, for the flu, it's not mandatory. It's, you don't get the flu vaccination, you have to decline it, and then there's a mandatory masking season.
Okay.
Then,
Okay, all right, so, and then, so you're finding that folks that have already resided in Bend are coming back because of some of the
are.
COVID stuff is,
Mhm.
Not as front and center.
Yeah.
And then, since COVID is not front and center anymore, are you seeing the workload still be high because of elective surgeries and other stuff that didn't happen during that time?
It is still higher. Yeah, there are still, and even we see it on our own benefits. We have a self-insured medical plan, and we're still seeing that fallout from that too, from people that delayed care during COVID. And so they are sicker or they postponed surgery and now it's a more complicated surgery. So all of that is still very much.
So you feel like high demand, even though, and then my last question is, do you find that some of your staff have difficulty taking their time off, even if they lose it? Like to actually like get up and out and take their time off?
Yes, so we don't lose it. They'll stop accruing, but once they meet a point, they'll stop if they're at the maximum, but they won't, like, it's not a use it or lose it at the end of the year or anything like that. But it is, we do hear from folks that it is hard to get their time off. Yes, they're accruing it, but they can't take it off because they don't have enough staff to cover. Some of that is true and some of that is just the person.
Right.
They don't want to leave their teammates.
Right. So we 100% support their ability to take it and we will cover, but that it's a little of both. Yeah.
Well, and just so you all are, we use traveling nurses as well, internally, because we too have a very difficult time recruiting nurses, even more so now with the competition with St. Charles Nursing. So we are really struggling with our nursing staff. So we do use travelers, and we used to use travelers for master's level clinicians as well.
Oh, really?
Yes.
That's very expensive.
Oh, very.
I did not know that.
Yes, we had to, on the crisis team, just keep stabilizations that are open.
Yeah.
Wow.
Yeah.
And we've got really high quality ones. I mean, like
Oh,
they've
yeah.
been really, it's been really a good opportunity. It's incredibly expensive, not sustainable, but it's a good, like, immediate fix in the moment.
Well, the nice thing with the travelers is it does give you an opportunity to shine for them, right? And then hopefully maybe lure them in.
Yeah, I know, we
Starting to stay here.
It hasn't worked that way for us, unfortunately. And look at the housing prices.
I did have one of the hills CNAs, because I did see that on the news, and they get assigned to different areas, correct? Do they rotate within their assignments so that they get a feel and flavor for different parts of
They do.
the system?
They do. And they also, one part that is a little bit of a dissatisfier for them is they a lot of times have to start at a night shift because that's where we have a big need. And so then they come in and they've committed to that. And then if that doesn't work for them, it's a little frustrating for them. So, but it's known when they sign up for the program that that's going to happen. But then they forget sometimes.
So often.
Yes.
With a fine print.
Yes.
And how often do you use like per diem positions?
We have a lot. So we call them relief caregivers at our hospital and we have a lot. A lot.
So like an
There's-
on-call pool?
It's
kind of
on
thing?
call.
Okay.
Yep. We call them relief per diem, on call. And it really varies depending on the unit on how they're actually utilized. Some are truly, oh, we've had a last minute call out, I need a relief worker today. And some are, you just tell me when you want to work and that's fine, you self-schedule. And so it just really depends on the unit. They have requirements that they have to meet a certain number of shifts per month or quarter or whatever. But as long as they're meeting that, then they're not held to a lot of strict standards as far as how much they have to work. And then you have some that work a ton of time.
I've had a dream of trying to collaborate on that issue, particularly when it comes to behavioral health workers for both safety PES, the ED even for behavioral health and our crisis services, or even other services within our department, to develop an on-call pool together that we can keep really active and busy between the two of us. And so that they, because as you know, the challenge sometimes is if they're not getting enough work, they need to go find something else so that they can have a more sustainable model, or they aren't trained enough. So when they do actually work, they've forgotten everything.
Right.
So if there's ever an opportunity, I would also really just throw it out there on any of your wellness stuff. Like I think if there's ever training or things like that, that we have a big focus on wellness. We want to do more with it. We have a county wellness department, which is great, but I think specific to healthcare is a very different type of wellness approach.
Yeah.
And so
That would be great. Yeah, that would be awesome. I also think an issue with the relief is we don't benefit them. And so if you need benefits, you're not going to sign up for a relief position. And I've always said, why can't you just build some positions that are relief but benefited? That's a draw, right? I might want to work relief and not as many hours. And so I would pay more for my premiums, but I'd be willing to fill in when you need it more frequently. And it just seems like that's an area that we at least try, but we haven't yet. So
Don't they accrue sick leave?
they accrue paid sick leave because they're not accruing ETO.
Right.
So they accrue paid sick leave. And that's, it's only 30 hours, 1 hour for every 30 hours work. So a max of 40 a year, but they do have paid sick leave. And they will be eligible for paid leave Oregon when my next headache comes. September. So we're really concerned about that, actually. So paid leave Oregon is the benefits become available September 3rd, and it allows workers to take off paid family leave for their own health or to care for a family member, bonding. It's state of Oregon specific. And we'll see a huge increase in the number of leaves, and the hospital is already off the charts as far as utilization. We have 400 to 500 new leave requests every quarter. And so now that we're going to have pay associated with that, our employee health leaves are really high. Our family leaves are about half. And I suspect that we'll see them become pretty close because now I'll have opportunity to have income while I care for my
Okay,
family.
so the current family leave is just they can use their hours.
Yep,
And now in addition, they're gonna get paid and they don't have to use their hours.
right.
Which.
I'm gonna like it better.
And staffing issues, right? Because more people are taking on. What is the age group of that on-call? Is that mostly retired? Are
It
people over
is
65?
across the board. It's a lot. There's where I see a lot of people that may have held a regular position and transfer into relief are new parents.
Okay.
So you'll see that demographic. You also see the retiring age demographic, and you see everywhere in between. They just that's the way they've worked that.
With a lot of the nursing units, you have to start as relief because you can't, like the union contract is kind of based on seniority moving up the chain. So then like I had to start and work relief for like 2 years before I got an actual position. Sort of the nature of the beast, but
Was that relief? Did it still provide like full-time work? Maybe not all the goodies attached to it, but.
yeah, not all the goodies, but yes, I worked plenty. And then once the like full-timers and part-timers hear that they can trust you and your work ethic and stuff, then they're like, hey, can I go on vacation here? Can you cover me here? You kind of get like a good deal going.
And we kind of, it's interesting to see it, but it does relate a lot to the behavioral health and services because the less efficient the hospital is, the more I know certainly for me, my work goes longer. Instead of a 2-hour wait, it's a 4 to 6 hour wait. Or I may not have a director's hold to be able to go because there's nobody working the PES. So that does transpire to us in the mental health field, or even clients that you guys might be seeing. It's hard to get into an appointment. So it's a really, that St. Charles Hospital is a main tool that we all use that I think we kind of forget about. Well, I don't think we forget about it.
It's easy to leave it out of kind of that equation when you're considering the other things, and it can be like, I can imagine a significant holdup in the process, so. And I think with the leads and the Oregon coming, it's not going to be any better for a while because our staffing will be low. I don't see the departments having the ability to staff up for that right now, especially when you don't know for sure your numbers. I mean, that's my guess that it's gonna go up by that much, but maybe it won't, because the benefit through the state is not, it's not super clear to a worker to figure out how much money they're gonna get as a benefit. So I think some people will be happy and some will be like, that's barely nothing. I have to use all my ETO to make myself whole anyway. So it'll be interesting for sure.
Thank you. Good discussion.
Yeah, thank you for coming. Yeah, thanks so much. It was really good.
Lots of innovation since I left the workforce.
Oh, gosh, so much in the last 3 years. It's unreal. Can't believe some of the things we pulled off at the county just like in per year. And I mean, even we've actually pulled off a lot of it over the first year. Like, I mean, just, yeah. And we've been wondering, I mean, a lot of it's been really, really good and stuff that'll last for, the rest of our time here. That we'll utilize.
Yeah. That's amazing. Used to be actually I was a union vice president.
Oh.
Jumped in a lot of those negotiations on both sides. It's just amazing what's happening.
It is.
I'd like to ask you, Paul, if there's anything out of the legislature that directly to IDD that you're excited about or angry about?
Don't get him started.
Well, he asked if I was,
30 seconds, go ahead.
yes. How's that? No, actually, no, not really. Our program we're staying fairly flat in terms of funding, which flat means, but that compensates for population caseload growth. So I anticipate I think we're going to be pretty healthy in terms of probably looking toward some FTE increase, of course, pending board approval. But yeah, no, there's a few bills that happened. One, probably the most marked one was Senate Bill 91, which is going to allow, so during the pandemic, there was an allowance to pay parents of minor children with really high needs to actually pay them to be the caregiver for their child, which has always been against Medicaid guidelines and still is. But there was an allowance during the pandemic, and I think it was state general fund that paid for that. Well, Senate Bill 91 actually requires the state to come up with a mechanism to continue doing that. So that's the big one. And it's actually going to be fewer kids that are going to qualify, and we're getting it through the period of the public health emergency. Because it was a finite amount of dollars that were allocated to be able to do that. So the state's going to be writing a new waiver to Centers for Medicaid and Medicare Services to have an equitable way, I hope it's equitable way to actually provide for that to occur. So that's the biggest one.
Okay, thanks. Okay, moving right along to announcements. Yeah, announcements we haven't covered?
I have one, and it could kind of also be combined with maybe a future agenda item, like an update on the fentanyl crisis. I sit on the Health Council Substance Use Disorders Work Group, and we just approved week before last $250,000 for increased Narcan or naloxone supplies throughout the region. There was about 10 people that applied, or entities, 3 law enforcement, Redmond PD, Prineville PD. Trying to think of the third, maybe it was Jefferson County EMS. anyways, it was really exciting to award those grants, especially to the rural folks, because they were sharing that EMS doesn't even have enough time to get to the overdoses in the very rural pockets of Central Oregon. So law enforcement are typically the first ones to get there. And because of the potency of the fentanyl, it's taking 2 to sometimes even 6 or 8 amounts of Narcan to reverse an overdose and save that life. So that project felt really good to be a part of. Yeah, and maybe just an update in the future for one of our agenda items on the count, like the harm reduction program or whatever, you know, how things are going with the fentanyl crisis.
Yeah, Karen, I can talk about that and get something if you want it for next month, or is that the plan?
I've been thinking about that as well as Captain Schultz. So we'll figure out next month. And
Okay, let us know and we'll.
We have some parking lot items around.
It's
Kinda get
Commissioner Adair. I'd love to say something, if you don't mind.
Go ahead.
The fentanyl issue, I'd asked months ago for Deschutes County to put up a billboard on the fentanyl, the deaths, 18 to 45, the leading cause of death. And driving last week when I left Deer Ridge, doing my tour, saw a huge sign, a billboard that Jefferson County has put up. They did it themselves. It's a phenomenal billboard because I'm hearing every day about different people overdosing and actually dying and what we need to do. Spent last week an hour on Opioid USA, a presentation out of Florida on what we need to do. So we've got to get, this has got to be on the agenda, I would pray, next month. It's really horrific. Talked to somebody on Tuesday. They just lost their niece who was 36, who died in Walla Walla. So, you know, we've got to get ahead of it. And I'm really hoping that the billboard that was in Madras we could have a similar 1 or 2 in Deschutes County, because I do believe people are dying. Rick Treleffin told me a couple of months ago, 3 people that were under their care this year. No, excuse me. 7 people in 3 months died of a fentanyl overdose and they were in their care. So the numbers are somehow they don't want these numbers to come out. And I do believe that we've got to, especially this group needs to get ahead of that issue. So thanks for bringing it up. It was on my radar to say something.
I'd just like to share what I learned yesterday. I do work at telehealth in California, and so meth is now being laced with fentanyl. And now when we're bringing people in that have a primary stimulant disorder, we're often referring to that treatment because of the fentanyl.
Lee, you probably have something to say about all this.
Yeah, fun thing, we just also made our own little, our names on it because we wrote the book, but no other, stuff like that. We have a little basic break the stigma education thing, including QR codes to where to get naloxone, us, Mosaic, OBOT programs. Feel free to take them and give them whoever you want, more color. We are seeing that fentanyl stays in UAs for up to 6 months of people being in our program, harm reduction, both including people with absolute clean dates and like the way that fentanyl metabolites staying longer than the actual fentanyl first initial drug screen. And it's just difficult. It's really made it difficult. What was a stable dose range for traditional heroin is higher now. It's taking longer to get people to a stable dose. It's just been harder, but the biggest thing that is contributing as a secondary factor is access to care and transportation. Aside from the fact, and I'd love to hear what to say about his program, for addiction, not pain management, we're one of the only prescribers this side of the mountains, unless other programs get developed and a lot of wonderful money coming down the pipe for methadone specifically, until you go to Pendleton or you go down to go up to Portland. But we have people, the rideshare program is broken. The OHP rideshare program is causing clients, and it is discrimination language that I hear, right? But that program is creating a huge problem and a huge barrier, and it disrupts when the dose works. We haven't had individuals since I started working at BTC in our care that have died, they may exit out. We have, Suboxone, methadone, that it's out there, it can help, but it's harder now. It's a lot harder than it was, but that rideshare thing is really, it doesn't matter, age. I'm seeing it in 70-year-olds and 21-year-olds on the rideshare, Crook County, Deschutes County, Jefferson, doesn't matter where they come from. And we put standing orders and they're not getting followed, including that process.
Is that something Pacific Source could help with?
I believe so. I know they have their own procedures there, and there's probably emails and things on the website. And I'm sure they
But
can answer.
Yeah, Callie, because I mean, this is, I don't know if you're following this, but I concur with everything we just said around rideshare and what feels sometimes like discrimination for our population and not being able to access it the way that others can, and being able to access the care that they need. And transportation is shockingly still a humongous barrier for our folks getting where they need to go. I've had experience, with our cab companies, it's been a real challenge. I've tried every avenue to try to develop relationships, contracts, whatever I can to get our people, prioritized or supported, and we've failed miserably, and it continues to be a huge issue.
Yeah, I'm happy to just step here and say that this barrier is definitely coming up across organizations, and we've heard it in several spaces now. And one of the things that's been shared from Pacific Source's end is sometimes members aren't filing the appeals or grievances. So we're trying to direct providers to help with that process. And you can just go to the appeals and grievance website of Pacific Source, because what's happening internally is there's not data to show that it's not working. So trying to get everybody on board to log that and call the customer support line when it does happen, because they just don't have enough data internally to bring it to Motive Care's attention, if that makes sense. So it's as easy as, just getting on the appeals and grievance website, having the number you made the call from, the member ID, their date of birth, and some of that basic information so that you can help file a report for that member.
We've been sharing that with staff, so expect to be seeing more of those, because
Good.
Yeah, and I hear you, because we get this from other places too. If you don't have the data to show, it's just anecdotal, and that makes it much harder. And I think we do need to document the heck out of this issue. Everybody's saying it. Yeah. Thank you. That's helpful.
Yep.
Hey, thanks for that, Leah. I drive our agenda a little bit. And balanced event. That Jessica's event or Dana's?
So, you have a little background on it. We'll try and be quick because it is time to close, but we do have an opportunity to liaison with other departments within behavioral health who will be attending the Bend Balance Festival that's held on a date I can't remember, in August, all day. And they are going to be representing from children to adults, I'm not sure, old folks, the crisis. And we have been wanting to get out and be at festivals. So I just want to pass this around. And if you are willing to volunteer a couple of hours, which I want to encourage folks to do, what day is it?
I think it's the 13th.
The 13th, and it's at Drake.
13th, yes, probably.
You won't have to do any setup or tear down. All you have to do really is sit down there and be available, and to have our stock card. That would count as one of our 2 goals this year, to be out in the streets a little bit. So I encourage folks to just kind of set aside sitting here and spend your time sitting there. So if you're interested, please put your name down, then I'll follow up, because I'm talking specifically to board members and not staff right now. And then while that's happening, I just want to say that we do have some parking lot items. Onboarding has been something that we've been pushing out. And we do have that ready to go for board members, which is important, because on the onboarding packet, there's some areas of not time restraints, but just like what participating in a board would look like. So we want to have that on a presentation so that board members kind of know what has occurred in that onboarding. So I just wanted to say that. Because if we do, and I don't care how it gets prioritized, I just don't want people to feel like that onboarding keeps getting pushed out and they don't get the benefit of the work that's been done to kind of coordinate a little bit more. So. That's it.
The last part I would add for the event balance is I also have a digital sign up that I'm gonna send out that Crisis will use. That's the paper version as well, so I know who to reach out to.
Actually, that was
But then
blank.
the digital one we'll give to Crisis and then she'll make a master schedule and reach out to you. So I'll be sending that out in the email.
And I just want to say that there's a lot of people going to be willing to volunteer, but this is one deliverable that will get the board a little bit more known. So I just really want to encourage folks to think about doing that.
Yeah, we'll have staff that are there to set it up and break it down and be there all day but like this is the behavioral health board specific.
Yeah, and we just have a card, so it's a very small role for a very big punch.
It's a fun event. I did it last year, spoke at it and it was well attended. And it was the first one I ever done. So I expect it'll be more well attended this time.
And a rec cart will be ready.
Yeah.
Thank you for this.
I haven't heard one more.
Well done. Yeah, really nice.
Well, can you just leave them at places like Newport and stuff?
Yeah, I mean, like, they kind of drop them.
I'll take a few and just drop them around.
Yeah.
You don't.
You said you have more in the car?
Okay. Thank everybody for being here.
Thank you.
We can continue our discussions with.
Well, you're